Hello, everyone. I'm very excited to be here. And if you want to know what the temperatures are like in Phoenix, so not quite this time of year, but in July, if you take your temperature now and put a 1 in front of it, that's what it is. Of course, that's, Fahrenheit. I don't know how to do Celsius, but the hottest it's ever been at my house is 122. So that's hot stuff. So, okay, so I'm here to tell you about my research on resident-to-resident aggression in the nursing home, and this is supported by John A. Hartford Foundation funding. So what I want to talk with you about this morning, it's still morning, yeah, is just give you an overview of resident-to-resident aggression, what it is, so that we're all on the same page there. A little bit about the research methods I use, but the primary focus is on the findings, of course, that's what we all care about, and then implications for practice. So, definition of resident-to-resident aggression, it's negative and aggressive physical, sexual, or verbal interactions between long-term care residents that in a community setting would likely be construed as unwelcome and have high potential to cause physical or psychological distress in the recipient. So it can be either physical, sexual, verbal, likely to cause distress if it happened to us in the community. And sometimes in long-term care, we just think, oh, that's what long-term care is about. People push you and people call you names. But if that happened to us in the store, if that happened to us at this conference, we'd be really upset about it. And it's the same for our residents in the nursing home. So that's the definition. More context here is that resident-to-resident aggression is the most common form of abuse occurring in nursing homes, at least in the United States. And I have abuse in quotes there because there's controversy about, do we really label this behavior as abuse? Because most of the time it's responsive behavior. People are aggressive because they're responding to some chaos in the environment or misinterpretation of what's going on. But of course, from the victim side, from the side of the person who's hit or kicked or pinched or verbally aggressed against, it does feel like abuse. So there's controversy about that. But what isn't controversial is it is associated with negative outcomes for both aggressors and victims. So certainly personal injury with cuts and bruises, broken bones, functional decline, mental health decline, reduced quality of life. Relocation, and for aggressors, that's typically involuntary relocation. They really don't want to leave the nursing home they're at to go to a different one. And then increased psychotropic medications, and typically that's antipsychotics, and all of the associated negative impacts of those. So the majority of incidents between residents does occur in the context of dementia, where the communication deficits hinder their ability to negotiate situations, to understand situations, to make their needs known. They act out their frustration around that by hitting out and doing some of these other things. And then their cognitive deficits limit their ability to cope in other ways. They can't talk it out like we can. It's more fighting it out. And then there are some of the minority of incidents don't involve people with dementia, and it's more your straight psychiatric conditions. And it's not so much, in those cases, it's not so much about cognitive decline or communication decline, but more about the impulsivity and the anger management issues and the need to control the environment in some way that's inherent with the mental health condition, and not having a large repertoire of other ways to cope. When we look at sort of motivations or triggers or whatever you want to call it that lead to incidents between residents. There's 5 different typologies, and one is social regulation, where there's that need to try to control the environment, tell other people what to do in the dining room, in the activity room, and getting into altercations around that. Social disinhibit. I can't say that word. Being socially disinhibited. There, I can say that. And that's about just not having that impulse control, not having that ability to self-censor, and just immediately reacting aggressively to an incident. Frustrated mobility, so a crowded area in the facility, everybody going into the dining room at the same time, everybody trying to get out of an activity at the same time, trying to maneuver down the hall, bumping into each other, incidents coming out of that type of situation. Invasion of privacy, so residents feeling like others are in their space, either their personal space while they're at the table or sitting, in the lobby, or actually, coming in to their room and frightening them, and incidents arising out of that. And last is the more hyper-vigilant, can't say that either, self-defense type thing, where they perceive a threat, and the threat may not actually be there, but they perceive it as being there and trying to protect themselves. So, where my study comes in is that one of the most common strategies to address resident-to-resident aggression in nursing homes is to make a referral to the facility social worker. But what we don't know is, well, then what does the social worker do? And what's the social worker's role in all of this? So I was really intrigued to find out what was going on there. So the purpose of my study was to identify the assessment and intervention strategies that social workers use to effectively address resident-to-resident aggression, and how they collaborate with their colleagues in nursing to manage resident-to-resident aggression. And I'm calling this like best practices, but just to be clear that I didn't actually measure outcomes. So it's best practices from the social worker's point of view. So what they feel has been helpful for them in getting a handle on resident-to-resident aggression. So I did a great bunch of interviews, 90 interviews with nursing home staff. Many of them were individual interviews, many of them were group interviews, so that's how we were able to do so many with social workers, social services personnel, and then different members of the nursing department, including directors of nursing, licensed nurses, floor nurses, medication nurses, and then the direct care workers, or certified nursing assistants, as we call them in the state. So primarily women in these roles, a broad age range from 18 to 61, and had been working in the facilities anywhere from a few months to several years. So a real broad, a diverse sample of people who provided this information. So what came out, and it's not surprising that what came out has to do with what I was interested in and asking about, were the key roles that social workers play in assessment and then in intervention. And I have collaboration placed where it is, because there's independent roles that nursing home social workers do in assessment and intervention, but then there's also overlap where they partner with nursing through the assessment process and the intervention process as well. So there's both areas, solo, kind of independent, what they do on their own, and then work that they do in conjunction with nursing. So with assessment, they talked about 3 primary roles that help them to manage and address resident-to-resident aggression. So first of all, it's around gathering information about what happened, ruling out potential causal factors, and then looking at the psychosocial impact for the person who's been victimized, and determining if more intervention is needed there. So in terms of gathering information, social workers really talked about the need for a very careful investigation. So they can't really do this willy-nilly. They have to really turn over every stone, so to speak, to figure out what really happened and what was going on at the time. So they did talk about this as being an investigation. They do a lot of individual interviews as they can grab somebody who witnessed the incident, overheard the incident, may know something about what happened, sitting down with that person and quickly talking with them and getting their point of view. Typically, they're collecting witness statements, so having people submit a written statement about here's what happened, here's what I saw, here's what I think contributed to the incident. And then they're participating in team discussions around these types of things. So really involved in the process of figuring out what happened. In terms of ruling out causal factors, they're looking at causal factors at all these different levels. So the physical factors, the psychological factors, environmental factors, and then looking at past triggers. What triggered this person in the past before they came here, when they were home with the family member or when they were in assisted living? And with physical factors, they're not actually doing the rule outs themselves, but they're considering them and thinking, boy, I wonder if pain was a factor here. I wonder if Mrs. Jones has an infection. I wonder if Mr. Smith, if that new medication is causing some problems. And then going to nursing and talking about their concerns. In terms of determining the psychosocial impact on the victim, they're doing follow-up visits to see how the victim is doing, talking with that person about, hey, how are you doing since this happened? Many times they talked about how the victim really had poor memory and couldn't remember the incident. And so in that case, they weren't just, oh, well, they can't remember, I'm just going to forget about it. They were really paying attention to, how does the staff who know this resident well, how do they feel the person's doing? Has any changes been noted in their mood, in their behavior, in their emotions? Have their usual interaction patterns changed? Has their routine changed? So if the person couldn't tell them how they were doing, they were observing and monitoring how the person was doing to see if there was possibility that, hey, they're not as talkative as they used to be before the incident happened. They're a lot more reluctant to come out of their room, or a lot more reluctant to go to activities. So noticing those types of changes. In terms of intervention, the role of the social worker, they talked about, they were helping to determine what interventions would be appropriate. They were employing preventative approaches, so things that were not after incidents had occurred, but preventing them from occurring in the first place, and then actually delivering interventions that were psychosocially based. So for determining appropriate interventions, they were doing a lot of ad hoc communication with other staff. What do you think would be helpful? What have you found helpful? Getting a lot of information from others. Participating in planned team meetings to discuss things that had happened and how to proceed. They talked a lot about incorporating a strengths-based framework, and that they were the primary staff members who were bringing that into the focus. So rather than labeling aggressive residents as this person, this is an aggressive person, we got to do something about this aggressive person. They were the ones who were really setting the stage for, no, this is a person who's aggressive in response to certain situations. So really framing it around that as a responsive behavior rather than a problem that inherently resides in the person. And then incorporating a person-centered framework as well. So what really triggers this particular person? What's meaningful to him or her? And then bringing that into the intervention. And then they also talked about how they employ very different approaches, depending on whether the person who was aggressive has dementia or does not have dementia. Very different. So they spend a lot of time talking about how the intervention process is very different depending on whether the person has memory and learning capability. In terms of preventative approaches, they're doing a lot of pre-admission screening of potentially aggressive residents who may be aggressive, and not so much to like limit access to the facility, but to be prepared, to really know what to expect, what triggers the person, what has worked in the past. So before the person even moves in, before they relocate, like we just heard about, that they're learning all they can about what's going to be helpful and preventative for this person. They also talked about how they do a lot of work to set the tone for a calm, respectful milieu in the facility, and they felt that that was part of their role, to make sure things were quiet, calm, that there wasn't a lot of chaos going around that would set residents off. Making thoughtful roommate assignments. So being careful who they put together in those semi-private rooms, and making a lot of effort to match people up who are going to get along. And they talked a lot about the importance of knowing their residents, really knowing who they are as people, spending the time to get to know them. Psychosocial interventions, they're really doing a lot that's entirely delivered by the social worker. Monitoring adjustment to placement. So if there's problems, they can intervene early. Negotiating problems between roommates and helping resolve that before it comes to blows. Facilitating room changes when it's necessary, for making that a comfortable process for all involved. Providing supportive counseling when it's needed to minimize psychosocial harm. Serving as a liaison and a help for families around these issues. They talked a lot about how it can be devastating for families to get that call that, oh, you know, your dad hit somebody here, or your mother did this, and so helping families through that process. Facilitating support groups, and this is for residents, primary residents with cognitive capacity, helping them to adjust to being in the nursing home, helping them to adjust to that communal living and the challenges associated with that. Negotiating behavioral contracts. That was for somebody, for residents with cognitive capacity. So they're not doing behavioral contracts with residents who have dementia, but with residents who, with their primary issue is psychiatric conditions, actually negotiating behavioral contracts. You know, here's the expectations of your behavior. If you're able to do this, you'll get X. If you're not able, we'll take away X. Those types of things. And then the social worker was typically the person who was managing extreme situations. So, you know, significant injury. We had a case where somebody hit another person, knocked their teeth out. They were fighting about the Super Bowl, of all things. And you know, it's a social worker who's calling the police, who's making the transfer, involuntary psychiatric hospitalization. Collaboration. Social workers talked a lot about consulting with nursing to determine the triggers, to devise intervention and plan for intervention delivery. And then they also talked about barriers, things that got in the way of collaboration. So in terms of working with nursing, a lot of ad hoc interviews with nursing staff to elicit their input. The plan team meetings to talk about behaviors and incidents that had happened. They talked a lot about reviewing the documentation of nursing staff to learn about maybe things that happened before, shortly before the incident. Intervention planning, sharing knowledge about residents' needs and preferences. So this was a lot of social work giving to other staff members about their insight and their understanding of what was going on with residents. And then again, the team-based discussions really talk a lot about that. In some cases, they were delivering interventions in conjunction with nursing, coordinating care. You do this part, I'll do that part. Before meals, I'll help in this area. During meals, you do this. So a lot of that type of thing. And then evaluating together what interventions were working and what were not. In terms of barriers, social workers talked about sometimes they wouldn't be informed of incidents of resident-to-resident aggression. So they'd find out, 3 weeks later that an incident had occurred, and then it was too late to really get involved in the assessment and intervention. And then CNAs, the direct care workers, also talked about that they had a lot of insight into how to manage residents' behavior and prevent incidents, but they weren't, their input wasn't valued. So, in closing, just want to talk about what I think this means for us as practitioners. So the idea is these are practices, good approaches that social workers I interviewed felt were helpful. So there's probably some things that you're already doing that they talked about. So then you want to pat yourself on the back and, hey, I'm doing good. And then to take a look at what you're doing and what social workers in the study are doing. And are there a couple of additional things that you could add to your repertoire to increase your effectiveness? And my idea is that you really, you can't, it's really hard for us to do everything. We're already doing so much. So the idea is to bring in more of those things that help bring social work values into intervention and assessment around resident-to-resident aggression. So knowing your residents and sharing that knowledge with other staff. We're already doing social histories and learning so much about our residents, making sure that other staff are aware of that. And I don't know about you, but when I was in practice, people didn't read my notes. So it's more about, we got to make our notes, but there's a lot to be said for those interpersonal relationships with other staffs where we're talking about these things. Incorporating that strength-based approach. This is a person with aggression, not an aggressive person. Looking at it from a person-centered framework, what makes this particular person tick, what works for them, what sets them off, and then utilizing the resources that are there, the knowledge of our nurses, the knowledge of the direct care workers. And I know when I was in practice, I didn't spend a lot of time with direct care workers. And if I were to go back into practice now, I would spend more time gaining insight from them. So those would be my recommendations.
Thank you.